Assalamu alaikum and good afternoon to all my friends, and good morning and good evening, because this is a very international audience. We are delighted to be back at, and I'm saying back, at the Center of Biomedical, Bioethics and Humanities, because we were there some years ago in physically with our entire team, and then your team came to visit us in Karachi. We have fond memories of our visit to Yogya and fond memories of your visit to Karachi, despite the gastrointestinal challenges that we presented to you while you were over here. So what I'll do is I'll take my, I can show my slides. I can do it, so I'm a co-host, okay, great. So I will just share my slides in a minute, and we should be on our way. Great. So can you see my slides?
Yes, all is good.
My slides visible? Great, okay. So what I will be talking about is that in the next few minutes, I will give you I was given these objectives for this talk in the invitation. So one of the objectives would be, how did my country cope with COVID-19? I'll try to cover that. And then what are the ethical issues pertaining to COVID-19 in the region? But I will focus on Pakistan, because the region has been very, very diverse in the challenges, ethical and otherwise, and the nature of the disease itself. So I'll talk about Pakistan. And how can bioethics contribute to solving issues that occur during COVID-19 pandemic? So these are the three objectives which were given to me. So I'll introduce the Center of Biomedical Ethics and Culture at SIUT to start off with. Then I'll give the national level of governance structure that we have had for COVID-19, coping with this huge crisis. Then I'll focus on ethical related measures during the pandemic and our experience in the end. So Center of Biomedical Ethics and Culture was inaugurated in 2014. So we're not all as old as you in Indonesia, but we are right behind you in our 15th year. So in the 20th year, we'll probably, hopefully have a conference similar to yours, but hopefully a physical conference with our friends from Indonesia also here, and also Paul Komisarov from Australia, who's also visited us. So we were inaugurated at the Center of Biomedical Ethics and Culture, inaugurated at the Sindh Institute of Urology and Transplantation, which is a public sector transplantation institute and one of the largest in the world. We became a WHO collaborating center for bioethics in August 2017. And our objectives as a center are focused on education, research, and as a bioethics resource for the country, region, and the world. We've been offering certificate courses in research ethics and clinical ethics. We've been offering postgraduate diploma in biomedical ethics and a master's in bioethics. Both of these programs, all of these programs are open to people from across Pakistan and abroad. And these are free of charge. Anybody who's selected does not have to pay anything to be in the course. We even provide free accommodation for our students. We have a series of workshops being offered, and also a newsletter, Bioethics Links, which is also online. So coming to the pandemic response at the national level, it struck us, so the first patient was diagnosed on February 26th of this year. While we were all looking towards China and the rest of the world, our first patient walked in from across the border in Iran, where some of our pilgrims had gone and come back with COVID. Very soon after that, within a matter of few weeks, within March, the government responded by creating what is called the National Command and Operations Center, NCOC, which is a very strong, very powerful, centrally placed command authority, which has input from all departments, including the armed forces and intelligence agencies. According to the center's website, the center is a one-window operation to collate, analyze, and process information based on digital input from human intelligence across Pakistan. And human intelligence has played a major role in our getting to grips with the COVID pandemic, to the point that public health services were not very well developed before COVID. And in this particular period of 6 months or so, we've actually developed them to a great extent, with input from all parts. During the pandemic, to cope with the various aspects, the NCOC has actually developed over 58 guidelines dealing with how to treat patients, how to do research, how to manage dead bodies, and they've been updating these guidelines throughout. The travel restrictions. We've now, only day before yesterday, we've started to open our schools and universities and colleges, and the guidelines for managing them, etc. So all these guidelines are very dynamic and have been coming out throughout, so that standard operating procedures can be made on these developing guidelines. One of the guidelines among these 58 is the COVID-19 pandemic guidelines for ethical healthcare decision making in Pakistan. I will be talking about this in a little bit further. So that was the major agency that was dealing with this. The two major areas of ethical concern that we identified right earlier on in the first week of March were COVID-related research review and regulations, because research review for COVID-related research must be done in a very different and a fast-paced manner. And also we were expecting how to cope with the impact on healthcare resources. We have limited resources in Pakistan, even in the best of times, but the COVID was going to stretch our ability to deal with healthcare for COVID-related and non-COVID issues. So we had to develop a set of guidelines, which we did. Which were looking at personnel, looking at the personal protective equipment, looking at medicines, hospital beds, ventilators, and eventually now vaccines. So all of these things were in our forefront research as well as clinical areas. So I'll focus first on the COVID-related research. We have what is called the National Bioethics Committee at the national level, which has a research ethics committee, which looks at research reviews, and healthcare ethics committee, which looks at ethics-related issues. So we also have the Drug Regulatory Authority of Pakistan, called DRAP or DRAP, at the national level. These two agencies, the National Bioethics Committee's Research Ethics Committee and the Drug Regulatory Authority of Pakistan, were looking at the COVID-related research, because that was about to bloom in Pakistan. There was research coming from all over the world. So we developed a rapid review mechanism at the research and ethics review level. Anything that comes to us at the research, at the secretariat of the Research Ethics Committee, within 24 hours is sent for reviewers who do a virtual review. Within 72 hours, meet and present their deliberations within 72 hours. Initially, our Research Ethics Committee would take 6 weeks in the normal circumstances, which of course luxury we did not have. So within 24 hours, within 72 hours, we would be responding, would hear back from the researchers, and we would again respond back within 72 hours. So we've dealt with over 50 such reviews in the past 6 months. So that structure, once it is reviewed and accepted by the Research Ethics Committee, it will then go to the Drug Regulatory Authority of Pakistan, to the Clinical Studies Committee, which will then only look at it after the NBC, the National Bioethics Committee, has approved them. So all clinical trials, drugs, devices, tests have to be approved, including COVID tests, including any drugs that are being marketed for this, any devices that are coming into the market, including new ventilators, etc., have to be approved. So that was the regulatory process, which we tuned up for the COVID pandemic. The other thing was our anticipation in the clinical arena of facing shortages of all sorts of things, including ventilators, as I mentioned before, personnel, how to deal with that. So we came up with the Clinical Ethics Committee of the National Bioethics Committee came up with the CBEC, with the guidelines, which were developed by CBEC, then approved by the National Bioethics Committee. These guidelines were available at this website that I've shown over here. They primarily deal with providing an ethical framework to assist in making difficult ethical medical decisions in light of the scarce resources, including ward beds, including ICUs, ventilators, medications, etc., including now vaccines as to who will get priority when the vaccine becomes eventually available, if it does. It reflects on the sensitivity of the relevance of the socio-economic conditions in Pakistan, and it allows healthcare professionals and institutions to formulate their own standard operating procedures for ethical allocation of these scarce resources. So these guidelines will say they're available for all institutions now to develop their own SOPs, the standard operating procedures, which they did. So these guidelines are focusing on the decisions for medical criteria are medical, but they should be free from biases and from discrimination. But the decision for allocating resources have to be medical. The decisions should be taken in a collaborative team effort rather than by one individual physician at the forefront or at the front lines. It should be a collaborative effort which is backed by the government, by the institution. The allocation of the criteria for scarce resources should be known by the healthcare professionals as well as the public. So whatever your criteria for that hospital is, that should be known to the individuals working over there and to the public. But also the institution and the government indemnifies the healthcare providers in whatever difficult decisions that they make in allocating ventilators, for instance, and refusing ventilators to one person and allocating to another person. These decisions are collectively taken but indemnified and supported by the institution. They also, looking at the context in which these are being working, one is, of course, that healthcare providers must be given priority when it deals in the frontline workers, including the ancillary staff, including the people in the janitorial staff, etc., to be given priority for healthcare if they develop COVID as a result of their work, because they need to be supported. So the hierarchies are very standard in Pakistan, but we said there should be no hierarchy. Everybody should have access who needs it, but priority should be given to the frontline workers at any level. We also said that since this is a family-centered community in Pakistan, the frontline workers, the first-degree relatives should also be given priority, since one of the fears for all frontline workers is that they would take COVID home and infect their parent, their mother, their father, their grandparent. So anybody working there should have this benefit that if, for instance, their family member is infected, they will also get priority for these scarce resources. This is a very unique thing in our guidelines, which we have not seen in anywhere else. Now, coming to the situation in Pakistan, how it has panned out, Dr. Komisarov mentioned about Australia. Here you can see our peak. We started off, as I said, in February and started to gradually increase. We peaked in June and we were projected to be peaking further in July and August. However, our curve has actually come down, alhamdulillah, to the point that in a couple of days ago, the data shows that we had 6 deaths, 404 confirmed cases of about 27,000 tests that were performed. So we've been able to bring the curve down, and we are hoping that the curve will remain down because of these measures that we've taken with all these standard operating procedures, etc. And as I said, we've just started to reopen our universities and colleges and schools, and of course, they're supposed to be operating in 50% their strength. Having days of, spreading out the students in the classes, etc., and all of that. And we are hoping that we will not see a rise after this, but life has to come back to normal. So in a summary, I've told you about how Pakistan coped with COVID-19, and it was a very rapid response by the government at the center and the provinces, and a very serious one. Initially, we had the lockdowns like wherever else in the world, but our economy is fragile, and we realized that we could not sustain a lockdown without causing rioting and widespread disorder. So the reopening was very quick, actually, also with standard operating procedures, but it was pretty quick with businesses opening up very, very quickly, as construction and other businesses also. The main ethical issues that I've talked about were the response to the ongoing research that we were expecting, and we developed terms of reference and response strategy very early on, and we've been able to maintain that. And we are now researching how long we will be able to do this 72-hour turnaround time, which we've been doing with Zoom meetings at starting at 10 p.m. because that's when people are free, going on to 2 hours after that, on practically every other day, including holidays, including Eid evenings. We've been doing these ethics reviews so that we can have robust research. We've also noticed that our guidelines for the scarce resource allocations have been utilized, but our resources have not actually been pushed to that much of a limit, in the sense that our ventilated beds never ran short, alhamdulillah, in our country. There were always some available somewhere or the other. But had that time come of resources to be distributed among fewer people, those guidelines were available. So a bioethics discourse was important at all these levels, to be able to predict these ethical issues that could have been coming, and to preempt them by giving guidelines and making terms of references and making systems, which we've been able to do. So my recommendation in the end, the last slide, is that a proactive approach is needed. The problem is not at all over for the rest of the world or for us. The proactive approach for us is also very much needed to address issues before they arise. This requires a wider discourse from across the country, from various levels of people. Such like, for instance, when we developed our terms of reference for our guidelines, we took input from various sources. When we developed our guidelines for the healthcare resource allocation, we disseminated it to a wider circle, got information, got feedback, looked at other guidelines from across the world, then developed our own guidelines, which, as I said before, are significantly different from other guidelines, but they are contextual to Pakistan and the work over here. So I recommend that that can also be done in other parts of the world. The governmental support at all levels in adopting these recommendations is extremely important. Otherwise, these things obviously cannot function. So thank you very much for this opportunity at being able to join this important session.